Welcome everybody, dear chairman, dear audience. My PhD topic is about the investigation of pathomechanisms of heart failure and the new methods for its treatment with and without drugs. I'm working at the Városmajor Heart and Vascular Center. My vision is to discover every single detail that can influence an outcome of a disease, and my mission is to find more personalized treatment for heart failure patients. I have two ongoing projects here at TMP with both the methodology of systematic review and meta-analysis. About my first project, which is about the predictive value of scar burden assessed by cardiac MRI on sudden cardiac death in cardiac resynchronization therapy patients. What we know is that the 5-year mortality rate of patients with heart failure and reduced ejection fraction can reach 50%, out of which 10 to 20% die suddenly. We know that scar burden believed to be a major cause of sudden cardiac death events, and the cardiac MRI is the most accurate diagnostic tool for assessing scar burden. We have a tool, ICD. This device is the gold standard device for treating sudden cardiac death events. But choosing the optimal device choice between implantable cardioverter defibrillator or CRT with defibrillator or without defibrillator would save more lives. What we miss is that there is no clear evidence regarding the guidelines in the optimal device choice. Our clinical question is that what is the association between the degree of scar burden assessed by cardiac MRI on sudden cardiac death in CRT patients? Our patient population is patients undergoing CRT. Our prognostic factor is scar burden assessed by cardiac MRI, and our only and main outcome is the sudden cardiac death events. Our hypothesis is that the higher the scar burden, the more effective is CRT-D in reducing sudden cardiac death events. As for clinical implication, the optimal device choice would decrease the mortality, the morbidity, and lower the complication list and the costs. After all, we found 16 eligible articles for our analysis. Regarding the results, we made a dichotomization based on the late gadolinium enhancement reports of the MRIs for a scar burden positive and a scar burden negative patient population. For the subgroup analysis based on time trend, we find no difference between the low follow-up time and the long follow-up time patient population. We made a univariate risk model where we found that using the measure of effects of hazard ratio, a 2 times higher risk of getting sudden cardiac death events in the scar burden positive patient population compared to scar burden negative one. We also assessed a multivariate risk model with a measure of effects of hazard ratio as well, and a ratio of 1.7 times higher risk of getting sudden cardiac death events in the scar burden positive patients. We also assessed a competing risk model, which we think gives us the best esteem, and it has the highest evidence level for mortality analysis, where we found that a clinical relevant data of 1.5 times higher risk of sudden cardiac death, but it's mathematically not significant. And we have a clear outlier data of Leiva's article, which is due to the low even number in the scar negative patient population. Basically, they almost had no sudden cardiac death events. We think that the most important finding of our analysis is the subgroup analysis of CRT-only patient population compared to the mixed cohort of CRT and ICD patients. Here we found that in the CRT patients, there were no difference in the sudden cardiac death events in the scar burden positive and negative patient population, while in the mixed cohort there were. We think that this is due to the reverse remodeling effect of CRT. As for summary, we think that this is the first meta-analysis focusing on CRT population regarding the topic with a relatively large number of patients, but of course we had some limitations as we had a quite heterogeneous patient population, and we initially aimed to get a cutoff value for the scar burden, but we didn't get one. And we had no comparison between the CRTP and D population. As for conclusion, we could say that the high scar burden is associated with 2 to 6 times higher sudden cardiac death events. In the CRT-only patients, the scar burden was much lower, and in those where there were no scar, the SCD events was negligible. As for implication for practice, the scar burden assessment helps detecting the ICD candidates, and for research, a uniform assessment method is definitely needed. Here we can see the status. Now it's on the Journal of Clinical Research in Cardiology under revision. For my second topic is also a meta-analysis focusing on the effectiveness of non-furosemide drugs with diuretic effects in the management of acute heart failure. We know that acute heart failure has a poor prognosis and a very high rehospitalization rates, accounting for 26 million hospitalizations each year worldwide. The treatment is multimodal, of course, but loop diuretics are the standard of care. They are cornerstone, but we know that they are stimulating the sympathetic nervous system and the renin-angiostensin-aldosterone system as well, which is unfavored in heart failure. The extensive use of loop diuretics can lead to diuretic resistance and thus worsening the kidney function, and because of this, it could lead to high long-term mortality rate. Our clinical question is that would combined loop and non-loop diuretic therapy prefers and leads to better overall safety and efficacy. Our patient population is patients with acute heart failure. Our interventional group is the combined diuretic therapy with loop and non-loop drugs, while the comparator group is the standard care with loop diuretics. We would like to measure the heart outcomes, the clinical ones like the length of stay, the mortality and the readmission rate, and also the congestive effects and the diuretic effects like the change in body weight, natriuresis, eGFR and serum biomarker levels. Altogether, out of 30,000 articles, we end up with 32 eligible articles. As for the progress, now we are at the data extraction phase. Thank you very much for your attention.
Congratulations for your nice presentation. My question would be regarding your first project. You mentioned that in the implication for future studies of for research that uniformization of the assessments would be needed. How did they measure the scar burden in your included studies, and what would be the ideal method for that, in your opinion?
Great question. I think this is something very important. Regarding the analysis, we use the late gadolinium enhancement method because it's the best, as we think, with the T1 and T2 mapping system. This is the best way to go. And we have qualitative analysis for that because they had reporting they weren't really reporting in all the cases the amount of scar, which would be useful for us because our initial aim was to assess the cutoff value, which could be based on the percentage or based on the mass of the scar amount, but the reportage of the data was not that so wide.
Thank you for the presentation, Richie. I don't know if I missed it, so you might have already mentioned it. I was just wondering, in your first project, what was the justification for splitting the studies into less than 42 months and more than 42 months?
Mm-hmm. Yeah, basically, we listed all the articles and just sum up the follow-up times, and we tried to make a split in the overall median follow-up time, which was 42 months. So we investigated those articles which were less than that and those which were more than that.
Okay, so it's not really a clinical definition, it was just the data you saw.
No, yeah.
And how big is the variation in each of the groups?
Basically, it differs quite much. Approximately the lowest data is around 20 mouse, and there were around 80 mouse as the longest one.
Okay, thank you.
Thank you.
If there is no more questions, I would have one concerning your first project. The patient population with reduced ejection fraction requiring ICD or CRT therapy is extremely heterogeneous. Do you have any data on the precise etiology of the reduced ejection fraction? Because myocardial scarring can be different in a valvular heart disease or an ischemic heart disease. Probably that's also a reason why you see that it's quite difficult to obtain only one cutoff value for all patients.
Mm-hmm. Thank you very much for the question. Yeah, I didn't brought the baseline clinical characteristics table, but altogether around 56% of the total population were with ischemic etiology. We really intended to have a subgroup analysis with the ischemic and the non-ischemic, but unfortunately we didn't have enough data, and we asked for the authors to get these data, but we couldn't manage to get them.
So Richie, let me ask you a question. The research question for the first project was related to the device choice. And you actually demonstrated that for scar burden positive patients, a more intense proactivity in device choice would serve them better, correct? So for those with scar burden, we should possibly consider the more intense devices. But is there any literature, is there any evidence that actually sheds a light on this observation? Are there any clinical studies where they implanted CRT-D for scar burden patients and just ICD or CRT-P for scar burden patients, scar burden positive patients?
Mm-hmm. Great question. Indeed, we don't have randomized controlled trial which is really randomized to CRT-P and CRT-D in this term. I think we have one ongoing project with the Poland site who is doing it right now. So basically we don't have data on that right now. From prospective trials, prospective observation trials, we have data on that, and it's concurrent with our findings.
Sorry. If we have time for one quick question concerning the second project, you say that you will have an additional diuretics. It will
additional?
Be additional diuretics. You will look for treatment strategies with an additional diuretics. It will be the SGLT2 inhibitors, or what will be your main focus? You will consider everything else.
Mm-hmm. We are not just only focusing on SGLT2 inhibitors because we already have some meta-analysis on this topic. We also wanted to investigate all the drugs used in acute heart failure with diuretic effects, so MRI antagonists and hydrochlorothiazide, thiazide diuretics are also taken into account.